So welcome back to the last session on liver pathology and the last session of the course. So this session is a slide seminar. I picked 3 cases to discuss 3 specific topics that we encounter frequently on our liver consult service. And if you are interested in other specific topics, please feel free to reach out to us, and we'll make sure to include that in our program next year. So let's start with the first case. I did replace one of the scanned case with a newer case here, but they do have a very similar diagnosis. So this is a 71-year-old man, had Waldenstrom microglobulinemia, referred to Brigham for new CT findings suggestive of cirrhosis with enlarged spleen. He had normal liver tests. He had normal total IgG level, mildly elevated SMA 1 to 80, negative ANA, normal alpha-1 antitrypsin level, no sign of hepatitis A, B, or C. But liver MRI showed with elastography showed the liver stiffness of 2.9 kilopascal. This is suggestive of stage 1 to 2 fibrosis, but also imaging showed recanalized umbilical vein, enlarged spleen, and intra-abdominal varices. He had no history of drinking or metabolic syndrome. He does not use herbal medicine, anabolic steroids, or acetaminophen. So he had a liver biopsy to figure out what causing the nodular appearance of the liver. So at low power, you already noticed there's no significant fibrosis. There's no regenerative nodule. The portal tracts are free of inflammation. There's no chronic hepatitis or interface activity. But more than 30% of portal tracts do show some abnormal looking portal vessels. In this one, we have a dilated portal vein that seems to herniate into the periportal parenchyma. There's another vessel outside of portal tract. And here again, there are some vessels outside the portal tract. And then within the portal tract itself, it's hard to find out where the portal vein is. And the hepatocytes showing this alternating hypertrophy and atrophy, and it gave rise to this very vague nodular appearance. With reticulin stain, you can visualize those nodules a little better, but the area with more reticulin stain are really just highlighting the area with more severe hepatocyte atrophy, not true fibrosis. So what would be the diagnosis for this case? I think you all kind of have some idea of what the disease is, but you probably all kind of confused what term we should use. Should we call this nodular regenerative hyperplasia? Should we call this idiopathic non-cirrhotic portal hypertension? Or can this all be non-specific? Because you probably have seen all these findings in other biopsy for different liver disease. Or should we use the new term portal sinusoidal vascular disease? So there's a lot of controversy regarding to this diagnosis, although we start to learn more and more about this entity. But we can start with something we all understand, which is the patient had portal hypertension. He had recanalized umbilical vein. He had varices. He had enlarged spleen. What caused portal hypertension? The most common cause for portal hypertension is cirrhosis, but there are other causes leading to portal hypertension without cirrhosis. And some of these etiologies are very well characterized, but a small percentage of patients, we don't really know what causing the portal hypertension. So these would be the so-called idiopathic non-cirrhotic portal hypertension. But first, let's just do a very quick review of the portal circulation hemodynamics. The portal vein collects the nutrient-rich blood from the GI tract. It enters the liver and drains into the sinusoids, and then eventually blood go into the central veins and flow into the hepatic veins and the vena cava. And blockade, obstruction, or vascular disease involving any segment of this portal system will lead to increased portal pressure. Let's look at some known causes. So before the portal vein enter the liver, the portal vein thrombosis can cause prehepatic portal hypertension. Some congenital venous disease can lead to increased portal hypertension. And once the portal vein enters the liver, but before it drains into the sinusoids, you can have pre-sinusoidal portal hypertension caused by most commonly granulomatous disease, such as granulomas in PBC or granulomas in sarcoidosis or schistosomiasis. These granulomas cause mechanical compression on portal vein, lead to pre-sinusoidal portal hypertension. And at the sinusoidal level, the most common cause for increased portal hypertension would be cirrhosis. But then in some other cases, especially alcohol-related severe steatohepatitis with severe sinusoidal fibrosis, these people may have sinusoidal portal hypertension as well. Infiltrative process, such as amyloidosis or infiltrative tumor, can also lead to portal hypertension. And as the blood entering, once we go into the post-sinusoidal segment of the portal vein, the most common cause for increased portal hypertension, including VOD, the preferred term would be sinusoidal obstruction syndrome. And then after the portal vein, after the blood leaving the liver, entering the hepatic vein and the vena cava, thrombosis, such as Budd-Chiari syndrome or heart failure, can lead to increased portal pressure as well. So all these etiologies can lead to portal hypertension without having cirrhosis. But our patient didn't have any of these conditions. So he truly belonged to this category of idiopathic non-cirrhotic portal hypertension. And although we don't really know what caused this condition, we do know this incidence of this disease is increased in patients with immunological disorders. It doesn't matter what kind of immunological disorder they have, any autoimmune mediated disease they seem to have increased incidence of this idiopathic non-cirrhotic portal hypertension. Also, especially in Asian country, chronic infection can cause idiopathic non-cirrhotic portal hypertension. And then exposure to certain medicine or toxin and some genetic correlation as well. And then people with prothrombotic disorder and hematologic disorder, again, is non-specific. It could be any hematologic disorder. And these patients seem to also have an increased risk for developing portal hypertension. So clinically, of course, there are signs of portal hypertension, such as varices and a GI bleed, large spleen, and abnormal liver enzyme, including abnormal alkaline phosphatase. And by imaging and a gross examination, the liver surface appears nodular. And also by imaging, you may see thickening of the portal vein wall. If there is an elastography done, the patients will show increased liver stiffness, although not as high as cirrhosis. And depending on where the obstruction or disease is involve the portal vein system, these patients may or may not have this hepatic venous pressure gradient. So how do we make a clinical diagnosis of idiopathic non-cirrhotic portal hypertension? This criteria was published in 2011. And to diagnose such a condition, first of all, we need to see clinical signs, unequivocal signs of portal hypertension. And then this is a disease of exclusion. You want to exclude cirrhosis on biopsy. You want to exclude all other chronic liver disease that may cause increased portal pressure. And also, you want to make sure the portal vein and hepatic veins are patent without thrombosis. And then you can reach to the final diagnosis of idiopathic non-cirrhotic portal hypertension. But what do you see on liver pathology, on histology? A variety of changes has been reported, has been observed in these patients. And a variety of terms have been used. You probably have heard all of them: hepatoportal sclerosis, obliterative portal venopathy, nodular regenerative hyperplasia, partial nodular transformation, incomplete septal fibrosis, non-cirrhotic portal fibrosis. But now we realize all these histologic changes are within the same spectrum that you can see in related to this disease. But we can group them into 3 subgroups. Some of them are portal vascular anomaly. Some of them are hepatocyte anomaly secondary to the vascular insufficiency. And then there is some degree of fibrosis, although none of them should have cirrhotic liver. Let's elaborate what do we mean by portal vascular anomaly. So as we all know, the portal vein showing on the upper panel, they usually are at least 3 or 4 times bigger than the bile duct or hepatic artery. And there are 4 types of vasculopathy has been described, and there are many terms have been used. And the highlighted term would be the recommended term for future use. So the first type would be stenosis or reduced caliber of portal vein. So the preferred term would be obliterative portal venopathy or portal vein stenosis. And then you may see a dilated portal vein herniate into periportal parenchyma, and the preferred term would be herniated portal vein. And then the third group include all these abnormal periportal vessels. There you see dilated portal and blood channels outside of the portal tract that do not seem to have direct connection with the portal vein. And then lastly, you may see multiple cross sections of portal vein in the same portal tract. This was called angiomatous, angiomatoid lesion previously, but now the preferred term would be hypervascularized portal tract. Let's see some real examples. Here in the portal tract, there's occlusion of the portal vein, so this would be the obliterative portal venopathy. And so this portal tract has 2 different findings: a stenosis of the portal vein and also abnormal vessels outside the portal tract. So this portal tract also have like reduced caliber of the portal vein, and then some herniation of the portal vein into the periportal parenchyma, and probably some abnormal portal vessels. Some of these histologic changes coexist and may have slight overlap. This is another example of abnormal periportal vessels. So this is an example of hypervascularized portal tract with abnormal periportal vessels. So because of these vascular changes, the hepatocytes may become hypertrophic and atrophic in certain area, depending on the blood supply. So this gave rise to the nodular appearance of the liver. So this is a so-called nodular regenerative hyperplasia, where you can see clear nodules without significant fibrosis. This is again due to the alternating hypertrophy and atrophy of the hepatocytes. And I think people often not aware that fibrosis do occur in these patients, although it's never cirrhosis. But they tend to be patchy, as shown here. That's why we call this incomplete septal fibrosis. And they seem to develop around the area with most severe atrophy. Those are the common findings of the histologic findings for idiopathic non-cirrhotic portal hypertension. So what about the specificity? If you see these, can you diagnose idiopathic non-cirrhotic portal hypertension with confidence? The answer is no. These lesions has been seen in many other conditions. It has been reported in normal liver in people without portal hypertension. It has been reported in steatohepatitis, chronic hepatitis C, and transplant liver. And so it's really rather non-specific. So what can we learn from these studies? We know that the spectrum of study, they do frequently present in people with the true diagnosis of idiopathic non-cirrhotic portal hypertension. But they can also see them in patients without portal hypertension and in patients with other chronic liver disease. That's why the new entity, portal sinusoidal vascular disorder, was proposed in 2019. So this new entity is supposedly to be a histologic diagnosis to include all the histologic findings we described earlier. The patient may or may not have portal hypertension. They may or may not have a coexisting, like other chronic liver disease. So this is a diagnostic criteria proposed by this article. I won't go through them, but this is here for your reference after the lecture. To compare this diagnosis with what we described for the clinical diagnosis of idiopathic non-cirrhotic portal hypertension, I think the absence of cirrhosis is still necessary. But there are some changes in this diagnosis, that absence of portal hypertension is okay to make this diagnosis. The presence of portal vein thrombosis is also okay because people have realized that portal vein thrombosis can be secondary to another primary portal venopathy. And then the presence of coexisting chronic liver disease is also okay. But the confusing portion of this new diagnosis is to make such diagnosis, you do have to exclude conditions such as Budd-Chiari and other disease with microvascular damages. And I feel this specific point will be improved or modified in future studies. So I think what's happening in these disease is really there is a real and a true group of patients have unknown etiology, idiopathic portal hypertension. This is a primary portal venopathy that involves a portal tract, a portal vein, or sinusoidal vessels. And this is a gradual process. Gradually, the portal pressure would increase with time. The liver function test may become abnormal, and the end stage will be nodular transformation of the liver. But if you biopsy this patient at the earliest phase of this disease, then you may see some of the physiologic changes without having clear clinical portal hypertension. And these changes may also coexist, or you can see them in other chronic liver disease, such as Hep C, steatotic liver disease. And there are two possibilities. One is these vascular changes are secondary to the inflammation or vasculopathy that related to the other chronic liver disease, or this is an independent process that just coexists with other chronic liver disease. Regardless of this possibility, this is still a gradual process. Both processes contribute to the enzyme elevation, to the increased portal pressure, and by the time of end-stage liver disease, it's unclear how much contribution from which component, because we just don't have enough data to evaluate that. But when you biopsy these patients at the earlier stage, then again, you will see these histologic findings as listed here. So, and now the biggest question is, how do we sign up these cases? So here's what we do. If you see vascular changes and hepatocellular regenerative changes, and these are the predominant findings in the liver biopsy, and we will document these changes and suggest a PSVD diagnosis. And if clinically there is portal hypertension, and then we would comment that the findings supportive of clinical diagnosis, the idiopathic non-cirrhotic portal hypertension. If there is no clinical portal hypertension, then we'll say in the comments that the findings may represent early or preclinical idiopathic non-cirrhotic portal hypertension. If other disease also present, such as chronic hepatitis or steatohepatitis, then we would document these vascular changes in detail, but we don't really comment or conclude the relationship to PSVD in the report. We grade and stage other chronic liver disease according to their respective criteria and guideline. But by documenting these changes, I think it will really facilitate the understanding of the disease in the future. To summarize this case that we talked about, the idiopathic non-cirrhotic portal hypertension, we talked about the spectrum of these histologic changes that can be seen in this disease. We talked about how these findings may be seen in patients without portal hypertension, and also these findings may be seen in people with other chronic liver disease. And I really want to emphasize the point of using these standardized terminology and documenting these findings, because this will really facilitate our further analysis, study of this disease. So that concludes the first case, and we'll just move on to the next case. So the next case is a 69-year-old woman, had history of GIST and had a resection, and the recent MRI showed a stable 1.3 enhancing liver lesion in segment 5-6. Her liver function tests are within normal limits. She had negative AMA. She underwent a biopsy for her liver mass. which is shown here. At low power, it's pretty obvious there's no obvious mass in this lesion, but you did notice some scattered area with a lot of eosinophilic material and increased inflammation. So at close-up view, a high power of these area, these are highly nice granulomas, and the Congo red special stain for amyloid is negative, in case you're wondering. And within these granulomas, you see those like a significant population of inflammatory cells, and most of them are plasma cells. And there is no portal tract in these areas. So given the presence of granuloma, the plasma cells, and the lack of portal tract, the diagnosis was made primary biliary cholangitis. So the patient came to Brigham, the hepatology service, for the management of her newly diagnosed PBC. But our clinician requested her pathology slides due to the discordance between the clinical history and the pathology diagnosis. Her liver enzymes are within normal limits. She had a negative AMA, and also she had this liver mass, and biopsy was met for the mass. So let's look at the case again more carefully. So although most fragments are very similar, but there was one fragment and does show a normal portal tract with a portal vein, a bioduct, and then the hepatic artery next to it. And then the fragment below that core look very similar, but it does have slightly increased level of steatosis and a mild lobular inflammation, somewhat increased the density of nuclei, and a more eosinophilic staining quality of the hepatocytes. And we did a group mean sensitivity stain, which showed a patchy staining pattern in that core with normal portal tract, but the other fragments all showed a non-specific weak diffuse staining. And again, at high power, just to show you that core with normal portal tract had the normal patchy staining, what you expect in the normal liver, whereas the fragment below it show a non-specific staining pattern. Among all the other stains we did, this is what LFABP showed. This shows loss of LFABP in other fragments. And the fragment, the core with the normal portal tract, to see normal retention of LFABP. So the correct diagnosis of this case is hepatocellular adenoma, and this is the HNF1 alpha mutated subtype. The reason I picked this case is to discuss this topic of well-differentiated hepatocellular lesion, especially like this one, extremely well-differentiated. A lot of people find this topic very challenging. So how do we approach them? So I think the first thing we need to decide is, are there lesional tissue in this sample? And if there is lesional tissue, where are they? There are a few clues you can use. First of all, as we already heard, that most hepatocellular lesions do not have intervening portal tracts. There are some exceptions, such as macroregenerative nodules in cirrhotic liver, regenerative hepatic pseudotumor, mass-forming ichthyosis, but the vast majority of hepatocellular lesions do not have intervening portal tracts. And then the lesional tissue often have very subtle morphologic difference from the true normal background liver. It could be degree of steatosis, degree of inflammation, size of the nuclei, size of the cell, the staining quality of the cytoplasm. And then you can use gluten synthetase to try to identify any normal background liver. And I also found CD34 to be very useful in this specific context, and I'll show you why. So here is an example from a 30-year-old woman, had the liver mass. The upper core is the normal liver with intervening portal tract. The lower core is the adenoma. And in addition to the absence of portal tract, the adenoma piece also showed a increased degree of steatosis and a mild degree of inflammation in the background. And also the staining of these hepatocytes, it seems to be less eosinophilic, more pale, comparing to the normal liver. This is another liver mass from a 55-year-old woman. Again, there are some subtle morphologic differences between the normal liver and the adenoma. The adenoma cells seems to be slightly larger, and many of them have this big balloon-like degeneration kind of change. So glutamine synthetase is a normal enzyme. The enzyme usually only expressed in hepatocytes around the central veins in normal liver. So this is what the glutamine synthetase would look like in normal background liver. But in liver lesions, regardless the nature of the lesion, they often show a different staining pattern. For example, this adenoma showing almost negative staining pattern of glutamine synthetase. And this lesion showed increased staining of glutamine synthetase. So glutamine synthetase would be a very useful stain to identify where the lesion is and where is a background liver. But I have seen a number of adenomas which seem to retain, keep the relatively normal appearing glutamine synthetase staining pattern. But that's very rare. So majority of lesions will show some difference comparing to the background liver. We already heard a lot about CD34. We know that CD34 was first suggested to use in the setting of HCC, because HCC usually have increased endothelialization of the sinusoids, whereas the sinusoid in normal liver is CD34 negative. But soon people realize it's not very useful, because a lot of liver lesions may have increased CD34 staining. But what I found very useful is it helps you to identify the portal tracks when the portal tracks are not obvious. So for example, here's a normal liver. There are some portal tracks. You don't really see the bile ducts very well in these portal tracks, but the CD34 really highlight the portal vein itself and also a small amount of vessel right next to the portal tract. But in the liver lobule, it's completely negative. So for adenomas, again, it will show a different pattern. For this particular adenoma, it showed increased CD34 in the lesional tissue. And back to our case, I also tried the CD34 in that core with normal portal tract. You do see the staining in the portal vein and a small amount of vessel next to the portal tract, whereas the adenoma seems to have increased rather non-specific staining throughout the lesion. So that's how you identify. Hopefully that will help you to identify the lesion and in the biopsy. And the next question would be, once you know the lesion is present, what kind of diagnosis you would give? So the main differential diagnosis for hepatocellular, benign appearing hepatocellular lesion in non-cirrhotic liver is hepatocellular adenoma and FNH. There are other lesions that could arise from non-cirrhotic liver, but they are much more rare. Here's a panel of image stain I use in this particular setting. LFABP, SAA, beta-catenin, glutamine synthetase, and I always do a reticulin stain to rule out HCC. And I found if you can only do one stain, I would recommend glutamine synthetase, and now I'll elaborate. Here's, again, is a very oversimplified summary for different types of adenoma. And I will just briefly go over some highlights, but I will talk about some recent updates and some possible pitfalls related to the diagnosis. So the first group is HNF1 alpha mutated adenoma. These are usually caused by biallele mutations in this gene. 90% of them are somatic mutations, and 10% of them arise in patients with germline mutation. And these people with germline mutation tend to have other systemic disease, such as mature onset diabetes of youth type 3. And then the tumor you may see multiple tumor in the liver, and you even see adenomatosis. That means there are more than 10 masses. And these tumors seems to have lower risk of malignant transformation but recent study has reported that this risk change as people age. In people older than 60, the risk seems to markedly increase. Then the tumor itself, the adenoma itself, tend to have diffuse steatosis, and the stain LFABP is very helpful in this setting. This will show loss of LFABP stain within the lesion. The second category of adenoma we are very familiar with, which is beta-catenin mutated adenoma, and this happens more often in men, larger mass with some degree of cytologic atypia. We all know that beta-catenin would be show nuclear positivity in these lesions, but I think it's worth to emphasize that the nuclear positivity tend to be very focal, only involves a handful of cells, but glutamine synthetase is actually a much better surrogate marker for beta-catenin pathway activation. Just to show you an example of beta-catenin activated adenoma, which really only show 1 or 2 positive nuclei. But glutamine synthetase, let's just spend a minute talking about this enzyme. This enzyme is only expressed in zone 3 hepatocytes in normal liver, but it is also a downstream target in Wnt signaling pathway. So when it shows diffuse positive staining, this is really a great indicator of beta-catenin pathway activation. So glutamine synthetase really have many use. It can show you where the normal liver is, where the lesion is, as we already talked about. It helps you to diagnose FNH, which have the characteristic map-like staining pattern. And this third use is what I want to emphasize is this is a great marker for beta-catenin activated adenoma, and it's much more sensitive than beta-catenin itself. And then it has some use in distinguishing dysplastic nodule and HCC. So the gene encoding beta-catenin, which is the CTNNB1 gene, is a really large gene, and there are many mutational hotspots, but only a handful of mutations and alterations that lead to full activation of beta-catenin pathway. And to simplify this matter, I think you can rely on glutamine synthetase when there is diffuse positive staining of glutamine synthetase. That's the best indicator of beta-catenin pathway activation. That also means the highest risk of malignant transformation. All the other patterns described here do not have the same high risk. So this is what a diffuse homogeneous uniform glutamine synthetase positivity look like. And this is a so-called diffuse heterogeneous pattern, or some people call this checkerboard pattern. We see them in certain mutations, such as the S45 position, but because it's not diffuse positive, diffuse and strong positive, this do not indicate the full activation of beta-catenin pathway, and so it does not have the same high risk of malignant transformation. So that's the beta-catenin activated adenoma. And then the third category is inflammatory adenoma. These occur more common in people with metabolic syndrome. The background liver tend to be steatotic, whereas the tumor itself tend to show sinusoidal dilatation, ductural reaction, and inflammation. And SAA or CRP are great markers to indicating the inflammatory nature of the tumor. But I think a relatively recent discovery is inflammatory adenomas can also have beta-catenin mutation. So even you have a diagnosed inflammatory adenoma, you cannot stop there. You still have to evaluate the beta-catenin pathway status. And we already heard about this. This panel should not be used to distinguish adenoma and HCC because a significant number of HCC can have positive staining with these markers. And more recently, a fifth group of adenoma has been reported. These adenoma can have an increased risk for bleeding, but the marker they recommend is ASS1, which do not work very well in most labs. So we don't really try too hard to diagnose this category. So the articles estimate up to 10% of adenomas may belong to this category, but as of now, we just we do not diagnose this specific type, and this would be adenoma, NOS. Those were for hepatocellular adenomas. Now let's quickly look at some other liver masses. This is a non-cirrhotic liver with this mass here. At low power, you already see fibrosis and ductal reaction. And this is glutaminyl synthetase, which show this characteristic geographic and map-like staining pattern. So this is FNH. And similarly, there's a fatty steatotic liver with a small mass. And again, the glutaminyl synthetase showing this geographic staining quality. And again, this is FNH. But when you look at these resection cases, you notice if really depending on sampling, if the needle, the biopsy only sample the area with diffuse positive staining or diffuse negative staining, it will be really hard to establish such diagnosis. But I think one thing we need to know is as FNH grow in size, it becomes easier and easier to diagnose by radiology. So for FNH bigger than 2 centimeters, it should be relatively pretty easy to recognize by radiographic studies. So when they really biopsy a liver lesion, they tend to be small, 1 centimeter or 1.5 centimeter. For these lesions, the chance of the needle only hitting the area with diffuse positive staining is less, not as much comparing to much bigger lesions. And also, the staining pattern in FNH is very characteristic. You have strongly positive area, you have completely negative area, but you usually do not see these weak, non-specific background staining. So that's another thing to keep in mind, that you really want to see really sharp demarcation between the positive area and the negative area. So here's a table you can review after the lecture. This helps you to distinguish adenoma versus FNH, but glutaminyl synthetase is really the most helpful marker to use here. And before we leave this case, let's quickly look at the different cases. This is a 50-year-old woman, had a liver mass, which showed this very benign appearing lesion. Even at high power, the nuclei are pretty uniform and small. Abundant eosinophil cytoplasm, you do notice there is some increase density of nuclei in certain areas. But this patient had a known history of renal cell carcinoma. So this is a metastatic renal cell carcinoma. So just to emphasize this point again, we already heard about this in the previous lecture. Before we sign out a hepatocellular lesion, we really should rule out other hepatoid tumor with hepatoid appearance. In this particular setting, I would definitely consider PEComa, metastatic adrenocortical carcinoma, metastatic RCC, neuroendocrine tumor. I think melanoma should always be in your differential diagnosis, regardless of the setting. And epithelial hemangioendothelioma, they tend to infiltrate through the sinusoids in otherwise normal-looking liver. So you really have to be aware of this entity and really look for them. So that to conclude this case is we talk about how to approach extremely well-differentiated hepatocellular lesion. We learn how to distinguish background liver versus lesional tissue. And one thing I want to point out is I always avoid diagnosing medical liver disease in target liver biopsy for mass. That's because most of these findings, portal inflammation, biliary obstruction, sinusoidal dilatation, they are commonly due to mass compression effect, like nearby mass effect, rather than a true background liver disease. And then the differential diagnosis for a well-differentiated hepatocellular lesion really mainly includes adenoma and FNH. And lastly, always rule out other metastatic tumor with low-grade hepatoid morphology. So we still have one more case. Well, just quickly go over this case. This is a 69-year-old man, had a liver mass. He has no other tumors elsewhere. And the biopsy showed this tumor with a lot of eosinophilic cytoplasm and more nested appearance. And there are some lumens, but it's unclear whether they are true glands or just space within these nests. You should have access to all these immunomarkers we performed. The tumor is focally positive for arginase 1, patchy positive for glypican-3. There's diffuse positivity for MOP31 and CK7, and negative for CDX2. So based on this, if this is all we have, I think because of the tumor show a lot of eosinophilic cytoplasm, in other words, haploid appearance, and also two markers, hepatocellular markers, arginase 1 and glypican-3 being positive. So I would favor this to be hepatocellular carcinoma based on morphology and the immunohistochemical profile. But fortunately for us, this patient has been sequenced elsewhere, and the sequencing showed TERT promoter mutation. So TERT promoter mutation is a very characteristic genetic alterations in hepatocellular carcinoma. So the diagnosis is pretty definitive, is hepatocellular carcinoma. The reason I picked this case is to talk about how do we approach carcinoma with mixed features of HCC and cholangio. And the distinction is clinically very relevant and very important because the treatment for HCC and cholangiocarcinoma are very different. HCC do not respond to chemotherapy, but the available option include sorafenib, which is a tyrosine kinase inhibitor, and immunotherapy. For cholangiocarcinoma, they respond to conventional chemotherapy, and also there are many newer targeted therapy available for cholangiocarcinoma. So the clinicians will want to know what kind of tumor this is. So here's a panel I use to make such distinction. Arginase 1 and HEPAR1, both are very good hepatocellular markers, especially arginase 1. I like MOP31 a lot to support the diagnosis of adenocarcinoma. Although some paper are reporting up to 30% of positivity in HCC, but in our lab, we found it's pretty specific. In 90% of HCC, they show negative MOP31. But the pitfall here, we need to be aware that MOP31 can also be positive in other carcinoma, such as neuroendocrine tumor, RCC, and urothelial carcinoma. So these are pitfalls we need to avoid. CK7 is not usable. I'm trying not to use it. CDX2 have very limited use. If it's positive, it definitely supports adenocarcinoma, but in most scenarios, it would return negative. Albumin-ish is not helpful in this particular setting. Here I summarized the genetic, how do we use genetic data to distinguish the two types of tumor if you have access to the tumor gene, the two NGS reports. So for cholangiocarcinoma, they have higher frequency of IDH mutations, BAP1 mutations, PBRM1 mutations, and the FGFR2 fusion. Whereas for hepatocellular carcinoma, they have much higher incidence of CTNNB1 mutation, TERT promoter mutation, and MYC amplification. I also want to use this particular case to clarify two confusing concepts. One is combined hepatocellular and cholangiocarcinoma. The other is a so-called intermediate cell carcinoma. So first of all, why this case is not combined hepatocellular and cholangiocarcinoma? It showed kind of both hepatocellular markers and cholangio adenocarcinoma markers. But the definition for combined hepatocellular and cholangiocarcinoma is you must have two morphologically distinctive population. It doesn't matter what there's no minimal cutoff of each component, but you do have to have two unequivocal population. One is HCC, the other is glandular. So our case didn't have two population. It has more uniform appearance. It just shows some mixed immunohistochemical staining pattern. And also, I want to point out that combined HCC and cholangio It's not distinct multifocal HCC and intrahepatic cholangio. It's not any form of hepatoblastoma. It's not a typical HCC, but with immunostain of CK19, also not a typical intrahepatic cholangiocarcinoma with hepatocellular markers. So this would be what a combined tumor look like, where you have the hepatocellular population right here, and then the glandular proliferation up there. The next concept that was new to the WHO 2019 is intermediate cell carcinoma. This is a very confusing concept, and I see very few studies on this particular topic. But this is meant to describe those papers with tumor with more primitive appearance, but show both hepatocytes and the cholangiocytes lineage differentiation. And also, very importantly, the entire tumor should be composed of this one cell type. There is no area with differential like HCC component or a cholangiocarcinoma component. It should be all uniform and in primitive appearing. So why our case was an intermediate cell carcinoma? Our our tumor has a very abundant cytoplasm, very haploid appearance. It doesn't really have that primitive appearance. And also, this intermediate cell carcinoma is really reserved for resection cases where you can see the entire tumor. This diagnosis should not be made on biopsy specimens. So this is what an intermediate cell carcinoma look like. Here we have a primitive proliferation where you have on high power are sheets of small blue cells, and the entire lesion is composed of the same type of cells. It shows just focal positivity for arginase, diffuse positivity for MOX31, but diffuse and weak, somewhat patchy staining for glycan-3. In other words, it is positive for glandular markers, but also positive for hepatocellular markers. By NGS, this tumor had TP53 mutation, which is not specific for any entity. So TP53 mutation can be seen in both hepatocellular carcinoma and cholangiocarcinoma. So this would be a real intermediate cell carcinoma. So hopefully in this case, we discussed how to differentiate HCC and the cholangiocarcinoma, the immunohistochemistry and genetic findings that could be helpful, and also try to avoid overdiagnosing combined HCC and the cholangio. So that really concludes this session. Thank you so much for your attention.